So this is what I was showing you, right? When you have the prolonged phase, you have more calcium coming in, and we have to somehow block this calcium inflow, otherwise you're going to continue this phase that's prolonging. So the reason why they give you treatment, right, of mag sulfate is that we want to stop, we want to make this phase shorter. We want to make this phase shorter, so it goes back, right, to repolarization. And so the treatment for this, right, as you guys said, we want to give them mag sulfate. So the chemical treatment is called correct their underlying electrolyte abnormality, right? Maybe they need potassium, magnesium, right? But here we give them mag sulfate. Even if their mag is not low, we still give them mag, right? And the reason why we give them the mag is because mag will stop the inflow of calcium, so it will compete, right? So let me show you, right, here. So the mechanism of action for mag sulfate is that it blocks the calcium channels, right? So it's compellingly blocking them. If I block the calcium channels, less of them are coming in, right? And I can go back to this type of morphology, right? And the heart rate becomes shorter. The other thing that's important here, right? We don't want to give them class 1A, class 1C medication, antiarrhythmics. We're not giving lidocaine, we're not giving amiodarone, as we just explained to you, right? So the treatment, again, as I said, is giving them mag sulfate. So IV mag sulfate. And then so this is your stable patient. Now you have an unstable patient. Right? So one treatment that I was showing you before, you guys are not allowed to do this in the field, it's not in your protocol, it's called override pacing. So if we, you know how we pace somebody at a heart rate of 60, for example, when the heart rate is low? I can pace somebody at a heart rate of 100 to 120. I can put it on the pacer, and I can pace them in a higher mode, and I can do so, right? And how is that helpful for me?
When the heart rate is faster, it's shortens the
Excellent, right? So, exactly. If you have a patient who has like significant bradycardia, right? And you start pacing them, override pacing them, you will shorten their QT interval, less chance of them going into torsades, right? And the other thing is if they become really, really unstable, right, and they alter mental status, then we can perform synchronized cardioversion, right? Some books, they'll say they don't even wait for synchronized cardioversion, they basically, they just defibrillate them, right? They say for sustained torsades, without any attempt to synchronize. But you guys are going to start with synchronized cardioversion when they're unstable, utilizing your protocols. And right, in some cases they even give them adrenergic infusion that's basically increasing their heart rate, right? Yeah.
Would you be able to sync with torsades because there's no like?
So yeah. So what I'm? Are you saying for this?
Yeah. So
Yeah. Yeah. Depends, right? Sometimes not. That's why they'll tell them to go ahead and give it unsynced.
So if I unsync, so I still start 100 joules unsync.
Yeah. Sometimes you cannot sync it. You won't be able to, right? And what happens is, you know what it does? It's kind of funny. The machine looks at it. Let me see if this will do it. So I put the torsades in here, right? And then let's put sync. Let's see if it syncs. Because sometimes what happens is, if it doesn't sense the R waves, it will not deliver the shock.
Oh.
So this sense in here, it sensed it, right? So it was able to, but some machines cannot. Yeah. So I say why? Because here it looks somewhat regular. So it's able. You see how it's flagging it at the top? So it's able to do it. But in some conditions, it will not be able to do it, right? So you will stay there, right, trying to give you synchronized, and you're pressing the button, it's not giving it. But here it looks like it's a good pattern here, right? So, and if that doesn't occur, right, then they say to give it unsynced. Does that answer your question?
Yeah.
Right. And then the other one was the override pacing, right? You basically set your rate above the person's heart rate, 100 to 120. We don't really do this, but that's was proven to work. There was a few cases like that. Right. So we talked about. So the dose is you're going to use your Reebok protocols to do it. So you want to remove this dorsogenic stimulus. They give you initial dose of 2 grams. What is the dose for us? 2 grams. Right. So mechanism we talked about, right? So let's talk about it because I see this. I saw this problem in the field, and I want to see how you guys do it. So we give 2 grams. We got a culprit. It's 10 ml of saline, right? Can I? You want to spike the bike, please? Right. So here, the issue is this. This mag that I'm holding in my hands, and this mag, they're all filled with 1 gram. They're all filled with 1 gram, right? So how much do I need to drop? 2 grams, right? So I'm going to show you what you're going to encounter if you do it improperly. So we're going to pretend we have a patient who has stable torsades, and we decided to, I'm going to come here. We decided to drop. Before you drop medicine, what do we usually do?
Check.
Yeah, we check 6 rights.
6 rights.
We do all that. Let's say everything is fine. That we have the correct syringe, we have the correct equipment. What is it that we do first once we start to pull up the medicine? Hmm? Yeah, we clean the top. So let me get the alcohol. So I clean the tops. What do I do then?
I would determine how much volume of the medicine I need.
So this says this medicine has 1 gram per 2 ml.
Okay, so I need a total of 4 mLs.
Okay.
So I would take 4 mLs of air.
Okay.
Well, it's in 2 bottles, so I would do 2 mLs. Pull it into the bottle, drop the drug.
Okay. So I'm gonna follow what you're saying. So look, I got 2 ml. I got 2 ml, right?
Okay.
I put it in my vial.
Uh-huh.
Put the 2 ml.
Word.
I got my drug.
You got your drug?
Okay. What do I do now?
Now repeat that process with the second vial.
But you see, I can't.
You would have had to have pulled 4 air initially and only put 2 in.
So what happened?
Did you pull 2
Huh?
mLs of air before?
So I see some guys who come on the call. They're like, oh. So you know what? This is what you do. This is what you do. I'm gonna dump this out. So what you do is this. You know you gotta take both vials, right?
Yeah.
You put 4 of air,
Okay.
right? What you do is this. You put 2 mLs of air, but you're not drawing any drug. Then you put another 2 of air here, and then you draw up the drug.
Okay.
So you draw up this drug, but now this one already has the air in it. So I don't have to put any more. So when I connect it, see it coming in. Right? So the technique is this. When you have 2 vials of this, put 4 of air, put 2 mLs of air into your first vial. Do not draw it. Just have the 2 mLs of air because they're vacuum sealed. Once you've done that, then you put the 2 mLs of air in your second vial, draw it up, and then in the first one there's already air, and then you basically connect it and you do it. So let's pretend I have we actually have another vial here. Put some air so I have it able to draw it up. So now I have 2 grams, right? So what do I do next?
100 mLs of saline? Oh, 10 mLs.
All right, so Georgie, come over here. So that's why I said never bolus your drugs. Always put a line on them in case you need to. So you see the port here. This port is for what? So, but I'm not giving medicine. So what I'm gonna do?
Draw out of it.
Yeah. How much? You could draw a little bit more, right? So I had 14. I'm gonna put 15, right? So I have 15.
Close mag.
Yeah. So now I have mag here, right? Now don't go away, Georgie. Right? So what's the next step?
You're gonna label it.
Not necessarily. So this drug, right? If I was going to do a drip, I could. If for this one, I don't necessarily need to label it. Why? Because I'm going to give it the whole amount right now, right?
Confirm with your partner that
Yeah,
you
we
have
confirm it. So what is the next step?
Secure the sharp.
Secure the sharp, all right?
Kink the line.
All right. So here's my sharp.
ask the patient or whoever,
Yeah, let them
about
know.
stable.
We're gonna see what is stable.
Just
So-
make sure the patient doesn't have to.
Georgie, you my patient. Pretend this is in your arm. What's next?
You're using that distal port right there?
Yeah.
You gotta clean the hub.
You're taking the line above the site of you're pushing the drug. So keep the line above it.
Okay.
And now push
Oh,
slowly.
And then I go very fast,
No, you
right?
don't.
No? How come?
Over 2 minutes.
Over 2 minutes, right? So exactly. So that's what I want to get into your mind, right? You're not gonna go like right all the way in. You're gonna look at your watch as I'm doing it, and I'm going slow. Sometimes I will take a little bit more saline. I would maybe even fill it up a little higher, like up to 20 ml, right? So I have that fluid there, so that I'm pushing it slow. And at the same time, you want the monitor to be in front of you, right? And I want to also be getting their vital signs. Obviously, the patient's not going to be standing. And it's a good idea if your partner is there. You want to already hook up, right? You want to make sure you have your pads available, and you want to have your 12 leads available. Why? Because once I administer this medication, right, and it takes its effect, let's say I see a change in my rhythm, I see a change from torsades to go to any other rhythm, I want to do a 12 lead EKG. Why do I want to do a 12 lead EKG?
To confirm.
To see any changes.
To see any changes, right? What changes may I see?
Oh, a shortened QT interval.
Okay?
Maybe electrolyte imbalances, maybe, because that's probably what caused this.
Anything else? So imagine he had torsades for half an hour.
Elevation, depression.
Why?
Ischemia.
Ischemia, right? Exactly. Excellent. So I'm gonna give this drug. I'm observing the monitor, and I have my partner probably have the pads ready, right? I'm probably not gonna open them up per se, but I have them connected, so they're ready. We're laying down. Definitely connect the 12 lead, right? So you want to have it done. You're observing the monitor. You push the drug over 2 minutes, right? Observing for the change, and then let's say I do have a change. I'm gonna hook up the 12 lead. So thank you. You could take this, right?
Question?
Yeah.
Do you follow it with the flush or?
Yeah, absolutely. So any medications you give here, the reason why I did not first connect the flush, I can do, Georgie, come back.
Yep.
So here, right, every medicine you give, you follow up with the flush, so good question. But here what I can do is this, right? Imagine I gave the drug,
Yeah.
I do this,
Disconnect
and then
yeah.
I do this, right? That's why I don't like the idea of bolusing drugs. So what I'm saying to you is I don't just put a saline lock and I give this drug and then this and then nothing. Because if I see untoward effects, I want to have the fluids in case I need to give the fluids, right? You guys love your fluids. How come you don't give your fluids? Right? So have this. You could flush it via this. By the way, anyone know how much fluid you need when you're flushing? Like, how do you know how much? A good idea to use.
10 ml.
So a good idea is you need 1 ml of fluid per inch of line. So if you're flushing from this point, this is how much you're going to see. So that's a rough idea. 1 ml per inch of your line. Okay, thank you. All right. So I'll show you this. Right. So we talked about how to draw it up. So remember, right? When you connect it, put the 2 mLs of air. Don't take it. Put the second vial, 2 mLs of air, draw it up, and then you take your other vial, right? Once you do this, right? So what we're going to do is, this basically says, we're going to correct the electrolyte abnormality. If you don't correct it, right, they may degenerate into VFib or pusilless ventricular tachycardia, and they may can also go that in case you give the wrong medicine, if you gave your amio, right, for them. This is a case I had, right? I don't know if you guys can see. Can you see the vital signs?
121/73.
Right? Pulse ox,
96.
right? And it gives you the correct heart rate, right? So the monitor is going to start beeping, V-fib, V-tach, right? And this was torsades. This guy was alert oriented ×3, right? No complaints at all, right? And so he got mag, right? And you see with the 12 lead, right? And you see still, right? It still did not fully resolve, but it's definitely better than this, right? You know how this may happen with you guys? You may be, you got that guy who, alcoholic, or someone called, the guy's laying in front of the building. You come talk to him, he's not alert oriented, you can't really automate him. You put him in the ambulance, and one of your partners decides to do an EKG. One of you guys decides to do an EKG. Oh, you got a student on board, and they put him on the monitor. What are you going to do now? It's beeping V-tach. You're like, let's shock it. Let's get amiodarone going. This poor guy, right? He's going to get shocked, and then he's going to get some amio to go with it, right? So please, if you're not sure, do the 12 lead, right? So, and if you guys are oriented times 3, is it ever VFib? No, usually not. There's only one condition that your patient has VFib and they can talk to you. There's only one condition. And it's very, very obvious.
They're good.
No.
The wrong monitor.
No.
Artifact.
Huh?
Artifact.
Not artifact. Well, it could be artifact, but let's say there's no artifact. Let's say it's legit VFib and the guy's talking to you.
You put it on the wrong guy?
No, you check if he has a belt, he probably has an LVAD. LVAD, right? LVAD is a device that when they have heart failure, they place it, it's like a pumping turbine. So check if they have a belt with batteries. And then look at his chest, if he has like something hanging off of it, and a belt with batteries, he probably has an LVAD. Those guys may have VFib, V-Tach, they'll talk to you. But other than that, right, there's no pulse with VFib. So if you see this, do the 12 lead, right? Give you mag, right? And, the reason why I was asking you why we do the 12 lead, this was basically, the reason why I want to show you this was the fourth definition of MI. So you don't think I'm making this up for you guys, right? So I was asking you the regular MI, you guys all know, right? You guys love to say this, it's the thrombus, it's the plaque, right? The guy has atherosclerosis, right? Plaque ruptures, platelets come in, heart attack, right? The other type of MI that can happen is second type of MI. So the second type of MI is these conditions here, but more importantly, I want to point this chart for you guys. So they say oxygen supply and demand. So see how it says sustained tachyarrhythmias and sustained severe bradyarrhythmias. So what do you think if a guy has torsades or V-Tach, right, for half an hour, 1 hour? Do you think there's a good supply to the coronary arteries?
No.
Right. So they may not get enough supply. The heart infarcts. You may have ST segment elevations. In the field, do you know if it was from this or it was from the coronary thrombus? No. Who would know?
Doctor.
The doctor, right? They got to take him to the cath lab, right? Come inside, put the dye, see if there's a thrombus. But this is very, very likely, right? A sustained tachyarrhythmia, bradyarrhythmia can cause a heart attack. And you may see ST segment elevations. Up to 25% of these patients have ST segment changes. Right? So do the 12 lead, please. Right? So this was that, and right? That's it, right? Any questions about torsades? No, indeed. Any questions about torsades? What drug we don't give them? Amio. Do we give lidocaine?
No.
No. Which drug we want to call for?
Magnesium.
Mag sulfate. What does that mechanism of action?
Calcium.
Well, not per se calcium channel blocker, but it blocks those channels to not allow calcium to come in. So the whole purpose of this, right?
Nikolai, it's like competitive inhibition of them? Or?
Yeah. So these are voltage gated channels. So I'm assuming because mag, right, MA, right, so positive, it will probably compete with them. It will
They're
compete with them.
very similar in terms of their...
Yeah.
So why don't we give a calcium channel blocker? Why
So-
don't we give diltiazem?
So in this setting, right, because the calcium channel blockers has other side effects that they may cause, right? So first of all, when you give a calcium channel blocker, besides the heart, right, where else you have calcium channel blockers? On your vasculature, right? What if this guy's hypotensive at the same time also, right? So you want to be careful. We give mag, regardless of their mag level. You don't know in the field what's their electrolyte level, right? And mag sulfate is the treatment of choice. By the way, even if your guy goes into arrest, the etiology of it, right, was still they need mag. So if you keep giving amio, you're not correcting their problem, right? So mag sulfate is the one they need. The other is coming to mind. When else we give mag? For asthma. Why?
It relaxes.
Smooth muscle, right? And calcium is when you contract your muscles, calcium plays a role, right? Calcium plays a role in contraction, right? Remember actin-myosin, right? So that's also, right?
Same thing for the seizures and
Yeah.
Yeah, but you're saying, but the same idea, magnesium is going to compete on a smooth muscle level too,
Yeah,
right?
yeah.
So, I mean, the danger of hypotension comes on a smooth muscle level regardless.
Yeah,
right?
but-
it's just less,
Yeah,
you would say.
correct.
Yeah.
That's why sometimes you call medical control when you give diltiazem, right? They'll say pre-treat them with calcium. Why they tell you pre-treat them with
In
calcium?
case they're low in calcium, so you don't, if they're low in calcium and you give the calcium channel blocker, you can have them go hypotensive.
Because on the vasculature, it will basically vasodilate them.
Yeah.
So they pre-treat them with calcium. I don't know if any of you had the experience. No, have you?
Which one?
Before you give diltiazem, the medical control says give
Wow.
calcium chloride.
Yeah.
Right, so it's same story, right? So the major takeaways, I told you the drugs, I told you what not to give. Unstable, you're gonna go to your regular synchronization, right? If you cannot synchronize, it doesn't give you the shock. Do not just stay there pressing this button, like how come it doesn't give it? Just give unsynchronized. Right? Any questions?
So the defibrillating torsade, will it ever convert it, or is it like a small like okay?
It will convert it.
It will
Yeah.
convert. So
And the problem is this: if it's sustained, you may go into VFib, right? Or you may have loose pulses with a sustained paroxysm. That's prolonged.
So you're still starting with 100 joules.
Yeah. You start with
Nothing.
you start with 100 joules. What I'm saying to you is, this rhythm that this monitor shows, it's kind of regular, and it's even picking this up. You see how it's picking this up? Let me just change it to VF for a second. So you see if I change this rhythm to VF, it's not picking up all the complexes. So and VF is irregular. So in torsades, you may have those paroxysms where the machine is not able to sense the R wave. You cannot see the R wave, right? And it's charged up, and you're pressing this button, and it's not engaging. So you're standing there like this, jamming it, right?
I have a question.
Yeah.
So if you're giving it unsynchronized, that's not like a separate thing. You don't need to call like night control. You can just like do it.
Yeah, because you're trying to give them the electrical therapy. They're unstable, but because the machine is not sensing the R wave, you're unable to deliver any energy, right? It's not picking this up. So at that point, you have no choice, right? You have no choice to give unsynchronized. Because this person is already unstable. You continue doing this, they are going to be in cardiac arrest, or they already are. You're just not sure yet. Yeah. Anything else? And just something that we're here for. If your patient, let's say you gave you MAG, patient was stable, it didn't work. What we're gonna do?
torsade,
Yeah, torsades, you gave MAG, didn't work.
transport.
Transport.
Yeah.
All right. So
Fluid.
fluid. So if they're not responsive to pharmacological therapy, you may call MAG control for more MAG, right? Or you may consider performing cardioversion on them, right? But before you do it, if your patient is alert, right, we got to give them. Which one?
Oh,
First.
no.
Photometer. How much?
So
Point 15.
0.15 milligrams per kilogram.
0.15 milligrams per kilogram, right? Max dose of 20, right? So here, I want to explain to you, make sure you actually do the math, especially for the new REMAC exams, they actually want you to do the math. Does everybody get 20 milligrams automatic? No, you're actually going to do the math. So it's a weight-based, right, medication. It's a short-acting, and the other important thing that is not said in the protocol, this one you do not want to give fast. You give it fast, you're going to get masseter muscle spasms. You get masseter muscle spasms on this medicine. So give it slowly, right? Have them connected to the monitor, have the oxygen flowing for those patients, and monitor their pulse ox when you give it, because they may have airway compromise with this as well. So just because you're giving them sedation for synchronized cardioversion, it can still take away the airway reflexes, right? Yes? All right. Any other questions you guys have? Clear? All right. You can stop.